Good morning, everyone, to the distinct moderators and also the member of the floor. So my name is Prasana. I'm actually the clinical specialist and neurology trainee in University of Malaya Medical Center. So today I have the pleasure to showcase my paper written on clinical characteristic and outcome of generalized myasthenia gravis in Malaysia, a single center experience. So we've conducted this study in my hospital, which is the University of Malaya Medical Center. So that's the single center. Okay. So this is the outline of my talk. We'll be going through introduction, objective, methods, results, discussion, conclusion. Okay, so without further ado, we'll start with the introduction. I think all of us know, myasthenia gravis is an autoimmune-mediated neuromuscular junction disorder that manifests as fluctuating weakness and fatigability. It is clinically heterogeneous and can be classified into subgroups according to clinical presentation. Some of them will have only ocular myasthenia gravis versus one third of them will have a generalized myasthenia gravis. And according to antibody status, seropositivity versus seronegativity, and at the age of onset of the myasthenia gravis, early onset myasthenia gravis, which is defined by age less than 50-year-old, and late onset myasthenia gravis, which is defined by age more than 50-year-old. Thymic abnormalities, which is largely classified as thymoma versus non-thymomatous. Okay, so the objective of the study is to explore the clinical characteristics of patients with generalized myasthenia gravis in our patient population based on the different subgroups, and to identify the potential factors that could affect the outcome. The methods, we've gone through, retrospectively reviewed our records of MG patients for the last 47 years, and patients with only generalized myasthenia gravis were included. We excluded patients with pure ocular myasthenia gravis and patients with incomplete records. And data on demographic, clinical characteristic, laboratory features, and outcome were analyzed. So we also would like to know what the disease control, which was assessed in the last visit, via the MGFA clinical classification. We defined less than 2 as good control and more than 2 as suboptimal control. And disease severity was assessed by MGCS composite score. It's a score which includes a physician examination and patient history, and the total score is about 50. And the outcome is also defined by the MGFA PIS scoring. So what is this MGFA PIS scoring? There's actually 8 category to it. So from that, we actually divided them into good, intermediate, and poor. So this is the study flowchart, where from 217, only 120 were eligible for the study. So the results. So this is actually the results of the 120 patients that we have. And from here, what we can see is that in the generalized myasthenia gravis patients in University of Malaya Medical Center, more females were seen having generalized myasthenia gravis with a ratio of 1 to 1.3. And when we looked about the age distribution at onset, we have a bimodal distribution. The females peaked at the age of 21 to 30, while the males peak at the older age, 61 to 70. And the other things that we also looked at was actually the MGFA classification upon diagnosis. As you can see here, majority of my patients here were having class 1 and class 2 disease on diagnosis. And also, we also did antibody status for them. 92% of them were actually positive to acetylcholine receptor antibodies. Unfortunately, we only managed to do only for 5 patients anti-MuSK antibody, and only 2 came back as positive, and the rest were actually seronegative. So, and in our patient, 40% of them actually had MG crisis throughout their journey. And also with the MG crisis, we managed them with IVIG. Half of them were managed with IVIG, and 17% of them were managed with plasma exchange. So normally the criteria we choose who gets IVIG and plasma exchange are basically mostly is due to cost. IVIG is quite costly in Malaysia, so plasma exchange is a cheaper version of it. And the treatment on the last visit saw our patients. If you can see here, most of our patients were on pyridostigmine, prednisolone, azathioprine. MMF is normally our second-line immunomodulators who have failed azathioprine or had complications with azathioprine. Okay. And out of the 120 patients that we had, half of them actually underwent thymectomy. And when we studied the thymus abnormality that was seen after thymectomy, also more than half of them had thymoma, 1/3 of them had thymic hyperplasia, and the rest actually had thymic atrophy. So, and throughout that period of review in our clinic, about 3/4 of them actually had good disease control. And this is actually based on our MGCS score. You can see the score actually from 9.2 became 1.9 throughout our follow-up. The outcome also, if you can see here, majority of them were actually in good outcome, where the complete stable remission, pharmacological remission, minimal manifestation, these are the majority of our patients are located at. Okay, so we look a bit more closer on the subsets of early onset myasthenia gravis and late onset myasthenia gravis. So what can we find out from them? So there were more patients of early onset myasthenia gravis that underwent thymectomy, while the patients of late onset myasthenia gravis and thymoma were more common compared to late onset. And also thymoma was more common in late onset, while thymic hyperplasia were more frequent in early onset. If you look at the sex distribution, the gender distribution in early and late, in early onset, we can see here 68% of them were females. And this was quite significant with a p-value of 0.011. And while we look at the thymus abnormality between early and late, as you can see here, the late onset myasthenia gravis patients had more thymoma, while the early onset myasthenia gravis patient had thymus hyperplasia with both significant p-values. And when we look again at the subsets of thymoma and thymic hyperplasia in our patients, the patients with thymic hyperplasia had good control of disease and less severe disease at the last visit. Okay, and both also had quite significant p-values. And in disease outcome from the post-intervention score, between early onset and late onset MG, a higher proportion of early onset MG had good outcome, while higher proportion of late onset MG had intermediate to poor outcome. So the discussion. So in my 120 patients that we analyzed, we had female preponderance. And in the age of onset, again, as we said earlier, had bimodal distribution, symptoms. Most of my patient had ocular bulbar weakness, which is MGFA class 1 and class 2B. And a very high majority of them actually had acetylcholine receptor antibody positivity. Myasthenia gravis myasthenic crisis were not common, was not uncommon, means actually quite significant, 40%. 52% of them had thymectomy. Thymoma was seen in 27% and thymic hyperplasia was 14%. Outcomes, 74% of them had good disease control, reduced in MGCS score, and 71% had good outcome based on MGFA PIS score. So the take-home message, if you can't remember any of this thing, was actually more females were early onset myasthenia gravis, had thymectomy and thymic hyperplasia. And in this group of patients, better disease control, lower disease severity, and better outcome. So the limitation in my study, because it's a retrospective nature of the study, there were incomplete and missing data in the medical records, especially in evaluation of initial visits. The number of patients of with seronegative and anti-mass antibodies were too small. Thus, we were unable to compare the clinical characteristic and outcome of our MG patients in different autoantibodies. Conclusion: female patients with early onset MG and thymic hyperplasia had significantly better outcome following thymectomy. Our findings were comparable with other studies. And these are my references. Thank you.